Well, welcome everybody. We are going to be looking at a big topic today. So although we've only got a limited time, and we'll try and do it as much just as I can. And it's looking at caring for people who need long-term tracheostomy tube and invasive home ventilation. And it's all about enabling a life worth living. So overview of learning, we're going to look at from a UK perspective, purely because I live in the UK. So we're going to look at how to care for adult patients with long-term tracheostomy tubes. So we don't deal with paediatrics in our long-term ventilation team, we are just dealing with adults. I want to look at how to understand how you can move patients from an ITU ventilator to a home care ventilator. And then finally, how to train and educate those caring for those patients who are going to be discharged home and make sure that that's safe. So what are the goals of long-term ventilation trachea tube care from going from hospital to home? The first thing has to be to enable that person to be the person they need to be. So they've moved from a catastrophic event or a prolonged chronic illness to having to have a long-term trachea and have to be ventilated. That's a huge life-changing event. So you need to try and get to understand that person and enable them to be who they want to be. We need to be able to give them informed choices. So often in acute care, we often make choices for patients that they may not want to have made. So we need to give informed choices. We need to ensure a life of quality for them. And out of that, we need to reduce the risks when they go home. However, you can't reduce all risks. And if that patient has capacity, they can make their own choices if they've been given that information. So although we're going to reduce risks, you're not going to get rid of them all. But we want to reduce hospital admissions. They don't want to go back into hospital again. They probably had a long time in hospital, so they want to get back to their life. So we want to reduce hospital admissions. And how can we achieve those? The real important thing for me and for our whole team that I work with is that you have to have holistic, collaborative, integrated care. And that means you need to understand different ways of knowing and doing, not just within a healthcare model, and especially within the Western biomedical model, but something perhaps outside of the box. That's really important, because if you don't do that, you can't enable that person to live again. So in order to do that, we need to understand that person, understand who that person lives with, and actively listen to them. Again, as I said before, we need to take informed risks in order to get them home. And a good thing that I have changed my wording from observation to watchfulness, because we should be watching what that patient is doing, how they interact with others, how they interact with their ventilator, their tracheostomy tube, and it's all about watchfulness. It's not monitoring, it's watchfulness. And it's about companionship. It's about being there for that patient and that family in order for them to move forward. And so companionship's really important. And having imagination and a sense of humour is also very important to leap over the obstacles that are often put in front of the patient and yourselves. And because it can be complicated, because it can be long, you need to have patience and you have to have compassion in order to move that patient forward. So the important thing for any patient who will need a long-term tracheostomy with ventilation is to get an early referral to the local long-term ventilation team, so that that patient can be optimised and discharged and given support outside the hospital. So some of the criteria that we use for being referred to the long-term ventilation teams in the UK is 21 days of mechanical ventilation. They usually have a tracheostomy. They usually have had 2 failed weaning attempts, and they have probably a known recent diagnosis of a neuromuscular disease or a spinal cord injury. These aren't set in stone, of course. So let's have a look at adult tracheostomy tube care. And this is the fundamentals. And not only do human beings have tracheostomy tubes, but dogs do too. And apparently there is a cow in America that has got a tracheostomy tube with a speaking valve so it can moo. Unfortunately, I didn't have a video of that, which would have been quite fun, really. So what's the current evidence, UK evidence and tools for looking after somebody with a long-term tracheostomy tube? Well, our current evidence from the UK is really coming from the National Tracheostomy Safety Project, which was developed out of our NCPOD, which is the National Criteria for Patient and out of deaths. So we needed to review what we were doing in hospital for tracheostomy care. And out of that, our National Tracheostomy Safety Project was born. However, although it gives us good guides and has some good tools in it, it does not replicate in the community. So it focuses on in-hospital management, which is great, but we can take some things for the community, but it doesn't cover the whole of the community. And most articles that you read are often for tracheostomies in the hospital, tracheostomy care in the hospital. So I was very pleased to find Barbie with a tracheostomy tube, which is great for our paediatric group. So what do we have to consider before the patient is discharged from hospital with a tracheostomy tube? And I think the first thing, and I know this seems very obvious, but is it the right tube for the patient? So as many of you are aware, most acute hospitals will have one type of tracheostomy tube because they have done a deal with that company. So that tracheostomy tube may not be the right one for the patient. Is it the right size? Is it the right shape? Does it have to be cuffed? What's the material going to be? Is it going to be plastic, silicone, PVC? And whilst in hospital, has there been, or are there any red flags still? Are there any granulation? Do we have tracheobronchomalacia? Have they had any major bleeding? These are the things we need to know before they go out. Because if they weren't documented and nobody knew in the community what the problem was, then you are putting the patient at risk. When was the last airway scope? And a lot of the time, tracheostomy patients, patients who require long-term tracheostomy tubes, often will come out of hospital without even have had their airways scoped prior to discharge. So we need to find out when the last scope was, and if there wasn't a previous scope, please can that patient be scoped prior to discharge? Is the upper airway patent, and that's going to have a big effect on whether that patient has got two airways to cope with when they're out in the community or just one. And that's really important for the carers to understand. So again, you're reducing your risks if you understand that and get that information. How easy is the change? Some of our hospitals do tracheostomy changes in the hospital with the patient always sedated. Well, that's not going to happen in the community. We need to find out, actually, can the patient have a normal blind change of their tracheostomy tube without being sedated? So again, you're reducing your risks. And where should the routine changes happen, and who should do them? Should they be done in hospital? Can they be done at home? Do they have to be done in a specialist ENT department? We need to know that information. Again, you are reducing those risks. And how does the patient communicate? Has they been seen by the speech and language therapist? Can they communicate? Has that been explored? And I think that's really important, because sometimes patients will continue having cuffed tracheostomy tubes when actually there is no need for them to have cuffed tracheostomy tubes. And again, can the patient eat and drink? Has that been tried? It's really important. How awful must it be to not be able to have that cuffed down and have tasters even to feel and to smell some food or liquid going into your mouth? So, adult tracheostomy tubes, what are they and what types are there? Well, there's lots on the market, and depends on where you live in the world what you can get hold of. For adult tracheostomy tubes, they must be double lumen, and that's a safety issue because we can take the inner cannula out if it becomes blocked and ensure that the airway stays patent. And so this is a really important thing to happen that if the patient has transitioned from pediatrics to adult, we change the tube to an adult double lumen tube. So there's lots of different tubes. There are PVC, silicone, plastic. There's cuff tubes, uncuffed tubes, silver tubes, and there's the fenestrated tubes, which up here. Now, most of the time we do not tend to use fenestrated tubes for long-term patients because of the fenestration holes, which can increase the risk of granulation and therefore increase the risk of bleeding for the patient. So therefore, I try to get the patients changed from a fenestrated to an unfenestrated tube. It also reduces those risks, and it also stops the carers having to change the inner cannula for a fenestrated one to a non-fenestrated one. Down here you'll see this is an adjustable flange tracheostomy tube. We try not to have those at all in the community for adults, and that is again because we are trying to reduce the risks, because the adjustable flange itself may come undone and the tube may move. So in order to reduce the risks even further, we try not to have adjustable flanges in the community. So let's have a look at routine tracheostomy care then. These are the essentials, and just to be quite clear that when somebody in the community, it is a clean technique that you're going to use. You're not going to use anything sterile. You're in the patient's home or you're in the care home. So it's a clean technique you're going to use with gloves and either tap water or bottled water. So the most important thing for any trachea with a person with a tracheostomy tube is the positioning. It needs to be midline. It shouldn't be pulling at all. The more you pull the tracheostomy from side to side, the more risk of granulation inside and outside. There's more of a risk of granulation inside and outside of the trachea. So positioning is really paramount, and that can be quite difficult when you are attached to a ventilator because the ventilator tubing will pull that. So it's really attention to detail is paramount for these patients. Effective humidification, I cannot stress enough. If you do not humidify a patient with a tracheostomy tube effectively, they will then have pluggy secretions and will dry out, and you then have a possible emergency. So it's really important to have effective humidification. If the patient has a cuffed tracheostomy tube, then you're going to have a look at cuff pressures, and you're going to have to monitor those in the community with your cuff manometer. Also, you need to look at how often they're going to have cuff deflation, if any, and when that cuff deflation happens. Tracheal suction to clear the airways, and I will go over these a little bit more in detail in a moment, but tracheal suction is an essential technique to learn. Some patients may not be able to clear their own secretions effectively by an effective cough, therefore the carer will need to suction those secretions out. Stoma care, very important to actually make sure that that's clean and not infected. Inner cannula changes, how often should they be done? How can they be cleaned? And some patients may go home with a subglottic port, which means there's a port above the cuff where you can aspirate the secretions that are sitting above the cuff. It's good for patients who have really copious amounts of secretions, but what I would ask first is, why does that patient have copious amounts of secretions, and can we reduce those secretions? The trouble with subglottic ports is, again, it's an extra hole that will rub on the trachea and increase the risk of granulation. So I try to change the patient to a non-subglottic tracheostomy if I can. And routine tracheostomy tube change is paramount. So there's a lot of equipment for patients going home with a tracheostomy tube. They need an emergency box. Now, I try to demedicalise most of my patients when they go home, so going out with a blue trachea case or a a Tracky box with emergency box on may not be the best thing for the patient. So some have their own emergency box that they customise themselves. So Maddie has her own little pink bag where she has all her emergency equipment in. So in her emergency box, there is a tracheostomy tube, the same model and the same size. The tracheostomy of a model of the same size, the same model, but one size smaller. There are Tracky ties, there's blunt-ended scissors, and they're just to cut the Tracky ties if you can't get the Velcros open quick enough. A syringe if the tracheostomy tube is cuffed, and lubrication gel. What I have got here is that in the community, we do not use tracheal dilators, and that's purely because most people do not know how to use tracheal dilators effectively. They can cause more harm if they do not know how to use them effectively. And the majority of patients' stomas in the community are established, and there's not too much of an issue of them shrinking down very quickly before the tracheostomy tube is inserted. A very important piece of information for when a patient comes out of hospital is the tracheostomy passport, and that can be developed by anybody, any company, and you can use whatever, but what it must have on it are the patient's details, the red flags that that patient has with their tracheostomy tube, the prescription of that tracheostomy tube, the contact details of the community and the hospital, and within that passport there should be a graded risk of change, knowing how easy or how hard it is to change that tracheostomy tube. So we grade the risk of change from 1 to 5, 1 being the lowest risk of all for self-ventilating patients, and that can be then, the tracheostomy tube then can be changed within the community, either by a registered nurse or a level 3 carer or a family member who has been trained. The 5th high risk is when you've got somebody who has severe dynamic airway collapse, tracheal bronchomalacia, and is unable to maintain their airway without the tracheostomy tube in situ. These patients will need to go into hospital and have an ENT specialist team. However, again, this is not set in stone. I do have a couple of patients in the community who are palliative, and so I will carry out that tracheostomy change with anticipatory medicine if I cannot get any tube in situ. So other equipment you'll need for tracheostomy tubes. You'll need to have an effective suction machine, and patients really do need to have a portable suction machine that is battery operated as well as mains operated, and it should have enough pressure within it to ensure effective tracheal suction. So there are some suction machines out on the market which do not do effective deep tracheal suction. However, you need to find out which ones work for your patients. A cuff manometer for the cuff tube, a nebulizer compressor or an aero chamber or an aerogen chamber or a MIDI device. The patients all need a bag mask valve for resuscitation, or if there is a sputum plug. So let's have a close look at what the essential routine tracheostomy tube care is all about. First one being observation. So we were given our eyes, our nose, our ears and our hands to look, listen, feel and smell. And they are great tools to have because you can look at how good that position of the tracheostomy tube is. Is it pulling? Is it in the right place? You're going to look at that stoma. Is there any granulation on the outside? Is there any granulation on the inside? Does it look red around the stoma? Is there any signs of infection? Really important to keep a very close eye on the stoma. Mouth care, paramount, especially if patients who are unable to eat and drink. If you do not manage that patient's mouth care effectively, then you run the risk of getting some nosocomial chest infections. So again, when patients go out of hospital, often if they're trachea and trachea ventilated, they never see a dentist. And from the pandemic, before the pandemic, we used to have mobile dentists that came to see our patients at home. At the moment, that's not happening. So there is a risk that they're going to get tooth decay. So again, we need to concentrate on mouth care. And then we need to look at the secretions, both the tracheal secretions and the oral secretions. And we're going to look at the odour. We're going to smell the odour. Does the secretions smell funny? Have their smell changed? That could be a sign of a chest infection. That could be a sign that they've got poor mouth care. Look at the colour of the secretions, the tenacity, how thick they are, how thin they are. And are they having some hypersalivation? If a patient has a lot of oral secretion, sometimes it could be that the tracheostomy tube is not the right tracheostomy tube, because it may be that the design of the tracheostomy tube and the curvature of that tube may be abutting the posterior wall of the trachea and causing hypersensitivity and hypersalivation. And just by changing the type of tracheostomy tube they have in situ may reduce the salivation and the hypersalivation. So again, your observation is attention to detail, really looking for those small little nuances that are going to make a big difference for your patients. And if you don't deal with them, then you're putting your patient at risk. So again, you need to think about cleaning the stoma and cleaning the inner cannula. Again, cleaning the stoma, you're going to just use a clean technique with gloves, and you're going to look at that stoma of how well it is, whether it's clean, whether it's got infection, whether you've got any granulation. The inner cannula of the tracheostomy tube should be checked at the minimum of 4 hourly, especially after you've just suctioned. However, it depends on the individual and what they're doing. And if they're at work and they're doing I've got a patient who is a barrister, and so if he's in court, I can't check that the carers can't check the inner cannula if he's in court. However, it does depend on the individual, but they should be checked and they should be cleaned. They shouldn't be cleaned with those, as you see, a brush, because that's going to damage the material. And I know that Portex are still sending out brushes with their tracheostomy tubes. I'd rather use a nice foam swab to clean the inside of the cannula, inner cannula. There should always be a spare inner cannula ready to use if the inner cannula has been taken out. So that storage of the clean inner cannula should be stored in a clean, dry, lidded box and not kept in a box with water or any type of fluid, because you're just going to increase the risk of infection. So looking at the cleaning of the stoma and looking at tying the securing the tracheostomy tube with a tie, when you're securing and the tracheostomy tube and doing the dressing, it should be a two-person technique. So 2 people should be there, one holding the tracheostomy tube to keep it safe, and the other one cleaning and then inserting the ties. So the tracheostomy ties should be changed daily or as required. If they get horrible and wet and sweaty, you want to change that, because they're going to get a nasty rash on the neck. Again, with the stoma dressing, you may not have to have a dressing, and some patients don't like dressings, and you don't always have to have them. So if the patient doesn't want a dressing, they don't have to have them. And especially if you're finding that a lot of the patient's stomas are getting red and infected, it may be worthwhile just taking the dressing off, especially at night time, to let that stoma air. And as you can see, there's quite a lot of different types of ties, not just the white ones. And I wish we could get these in the UK, but we can't. So, as I stated before, effective humidification is paramount for these patients, whether they're self-ventilating during the day or they're ventilated. And you can either have active or passive humidification. And by the active humidification, I mean using an electrical heated wire humidifier, such as the Fisher & Paykel MR850 or the 550. You can use a nebulizer, you can use the heat moisture exchange, you can use a Buchanan bib if you're not ventilating a patient, or the heat moisture exchange filter. If you've got somebody who's going to go out and about in their wheelchair and ventilated, you can use your nice heat moisture exchange filter here. The most important thing as well is that you need to ensure the patient is well hydrated. So if they're not drinking enough, then their secretions are going to get nasty and thick. What I want to draw your attention to is the upper airway restoration valves, the one-way speaking valves like Passy-Muir valves. If a patient's going to use those without ventilation, they are not going to get any humidification, because as the patient breathes in through the Passy-Muir valve, the valve closes, the air then is directed all the way up through the upper airway, out through the nose and mouth. That means that the patient has no humidification. So just be aware that if your patient's wearing their Passy-Muir valve or their upper airway restoration valve, one-way valve, during the day without any ventilation, you may need to give them extra nebulizers just to ensure that the secretions aren't going to get too thick and sticky. So, clearing the secretions within the trachea. And tracheal suction is to stimulate a cough and to clear secretions. Some of your patients may not have a cough, so you may need to do deep suctioning, tracheal suctioning, in order to clear secretions. Some may have a cough, but not as effective, so you are going to suction to stimulate that cough to clear those secretions. Again, it is a clean technique, and although they may have had a closed suction device in the intensive care unit, we tend to go to the open suction in the community because, again, it stops another piece of equipment being on that tracheostomy tube and looking medical. You use one suction catheter per suction. You need to make sure that you've got your 2 suction machines that are both portable at home and that they are high pressure suction machines. Remembering that suction in the hospital is wall suction, suction in the community is via the electrical pump and atmospherically driven. The whole process of putting a suction catheter down and then suctioning the patient should take no more than 15 seconds, but it's an individual thing. So I have some patients who like me to go down their tracheostomy tube and suction there for about a minute. That's up to them. They're quite happy. Nothing happens to them. So again, it's knowing your patient and it's on an individual basis. And again, the frequency of those suctions will depend on the individual. And you may have care plans coming out from hospital saying this patient needs 2-hourly suctioning. I would probably question that. They probably don't need 2-hourly suctioning now. Now they're over their acute time and acute medical issues. They probably just need suctioning when they require it. The depth of the suction is, if you're going to do deep suction, that means that goes all the way down to the carina. There is no graded measurements to go down. That happens in pediatrics because their trachea is growing. Once the patient has become an adult, they will not grow any further. So the depth, when we talk about deep suctioning, is to the carina, pull back slightly, then place the suctioning on and suction those secretions. So, when should routine tracheostomy tube changes take place? Well, there was a study in 2009 from Sweden that demonstrated that the trachea tube material degraded after about 3 to 6 months. It's a very interesting article. So, although there's not really much evidence to tell you when to change it, this is quite a lovely study to actually show you that after 3 to 6 months, the material does degenerate, and then that puts the patient more at risk of an infection. So routine tracheostomy tube changes should be based on clinical need as well, and you need to know the patient and how that patient is. And planning is paramount. If you're going to change the tube at home, you need to decide it's not going to be 2 o'clock in the morning, because you need people around you. You need to be able to call an emergency ambulance if there's a problem. So planning is paramount. It's a 2-person technique, and the people who are going to change that tube should be competent in doing that and know what to do in an emergency. So you must plan it. Don't do it at, as I say, 2 o'clock on a Saturday evening. As I told you, 2-person technique. It's a blind exchange. So you're just going to use the introducer, and you're not using any scope to change the tracheostomy tube if you're going to do that in the community. And again, it's a clean technique. It's not sterile. And your patient does not have to be nil by mouth before the tracheostomy change, as they often are in hospitals. So I usually, if I have to go and change the tracheostomy tube on patients, I get a time, they are ready for me. They've often had their breakfast, but that's not going to stop me changing their tracheostomy tube. It doesn't take more than 2 minutes to change an easy tracheostomy tube in the community. Communication with a tracheostomy tube is so important for our patients. And it could be via invasive ventilation, or it could just be self-ventilating. So what we have to distinguish first is that they got a patent upper airway. If you haven't got a patent upper airway, then they will not be able to communicate effectively. So you're going to have to think about other forms of communication. And this is where we do a really good MDT with our speech and language therapists in hospital. If we're lucky, we can find a speech and language therapist in the community, but they are as rare as hen's teeth in the UK at the moment. But we do work very closely with our speech and language therapists in hospitals. We need to get that cuff down as quickly as possible. And if they can cope with that cuff down, how fantastic is that? Because then we can perhaps think about leak speech if they can't cope with a speaking valve. But at least we might be able to get some airflow over the upper airway so they can make some noises and speak. We might want to do a finger occlusion or a cap. So one of my patients has a really bad upper airway stenosis. However, she can do quick finger occlusion just to get some words out, but she can't cope with any cap or speaking valve. So what's best for that patient? We can use speaking valves, which can be open, and we can use the upper airway restoration valve, which is the one-way speaking valve, which is quite common. You can use either that straight onto the tracheostomy tube here, or you can use it in line in the ventilator circuit as well. You could, if they've got leak speech, increase PEEP on the ventilator, and that often can increase the patient's volume and voice if you increase the PEEP on the ventilator. Or there is the above cuff vocalization, which I have used in the community, and sometimes it works well. However, what you have to remember is that if you're going to be putting air through the subglottic port of any description, you're going to dry up secretions. So it may be that the secretions get too dry and crusty if you're going to do above cuff vocalization. But if it means that the patient can make a decision or be able to talk, then do try it. There's nothing wrong in trying these things. It's really, really important because it means the patient can communicate. Even if they just make a sound, for them to hear that sound, it's their voice, and that's really important. If you can't verbally communicate, then perhaps a writing pad might work, or a computer for eye gaze. And again, you'll be ringing other speech and language therapists, OTs in to find out how we're going to manage those patients with either eye gaze or using a button on the computer. So having a long-term trachea is going to have its complications. I think the first one that I think we forget about, especially when patients come out of hospital, is altered body image. A lot of the time, patients who have had tracheostomy tubes and have been in hospital a long time haven't even seen themselves in a mirror to actually know what a tracheostomy tube is. And we've all been guilty of not showing the patient what a tracheostomy tube is. This is what is inside you. This is what it looks like at your neck. So be aware that they will have an altered body image, and we need to deal with that. We need to discuss that with the patient because it's really important. Infection, of course, is going to be another issue, and that could be infection of the skin, infection, a chest infection, infection of the trachea, although I don't see much tracheitis in our patients, but that's because they've got very good oral and tracheal suctioning techniques and hygiene. Granulation, and here you can see the granulation on the inside. This is the tracheostomy tube, and this is a patient I recently scoped, where you can see the granulation just below the tracheostomy tube. The patient was in respiratory distress and had very noisy breathing. I therefore put a longer tube in to bypass that granulation, and her respiratory distress stopped, and she's much happier now. You also can get very nasty granulation tissue on the outside, and again, the granulation on the outside, often we will treat with silver nitrate topically once a week, just to ensure we can try and burn that off, and the carers who are looking after that patient will be taught how to do that, and it will be prescribed by their local practitioner, general practitioner. You may get stenosis on the upper airway or below, and also there may be tracheal bronchial malacia and dynamic airway collapse. These two things can happen gradually. They can happen in acute, so when the patient gets a chest infection, they can get tracheal bronchial malacia because of that acute infection. After the infection has gone, you may not see tracheal bronchial malacia again. So trachea tube emergencies, and you can see a few here. Here's a blocked tracheostomy tube that had to come out with a great big piece of sputum at the end. And if you have a complete blocked tracheostomy tube, you need to take that tracheostomy tube out because you have no airway. This will show you a really good example of how smoking damages your health. So this is a gentleman who it was trachea ventilated and smoked when he was on his ventilator, because that's what he liked to do, and this tracheostomy tube needed to be changed weekly because it would get into this state and he would have lots of blockages. And then you've got some frank blood. So you'll have sputum plugs unable to pass suction catheters for either sputum plug or stenosis or tracheal bronchial malacia. You'll have dislodged tracheostomy tubes that can either be partial or total. You may have fresh heavy bleeding, although this is very rare in the community unless you have eroded the innominate artery, which is sometimes can be an issue. And one way you could think about dealing with that, if you've got somebody who's got a really bad kyphoscoliosis and they have a long-term tracheostomy tube, what we would recommend is that you do a CT scan yearly to ensure that scoliosis is not impacting upon the position of that tracheostomy tube that may be impacting upon the innominate artery. So the most important thing to reduce the risks of these tube emergencies is to have home emergency algorithms written by the team. And this is one example that I use for our patients in the community. So we should have guides to care for our carers who are looking after these patients. So we should have troubleshooting ventilator alarms so they know what to do if an alarm is going off. They should have a respiratory assessment in the community because they're not going to have things like CO2 monitoring. So they need to look at what can they see from a respiratory assessment and what is important. Management of possible chest infections, and again that's based on an individual basis, and what we often will say is if they reach a criteria that they look like they're having a chest infection, then we start the rescue antibiotics that are in the home straight away. Then we will take a sputum specimen. The carers need to know what that patient's routine is, and that should be written down so everybody knows what the routine of care is. Again, that tracheostomy and ventilator passport with all the prescribed settings and tracheostomy tube. And again, as I said, emergency algorithms that are going to have sputum plugs and what to do with the dislodged tracheostomy tube. So that's a quick sort of whiz through transitioning for a tracheostomy tube patient. But what about transitioning to home with a tracheostomy tube and a ventilator? Well, these are all the ventilators we see. Don't see these hardly anymore. Our lovely iron lungs, which I grew up on, but fantastic they were and saved lots of lives. But what you must remember is if you're going to have somebody who's trachea ventilated, some ventilators are not licensed for trachea ventilation. They're only licensed for non-invasive ventilation. What's the difference between an ITU vent and a domiciliary vent? ITU vents are for those who are acutely unwell, and they run on compressed air and oxygen. They can give 100% oxygen. Often won't have a backup battery, and there's no leak compensation, which means it's very difficult when you want to take a cuff down. You want them to get the patient to talk because the ventilator will keep on alarming, even if you put it on the NIV mode. Our domiciliary vents, however, should be portable. They have an internal battery. They run on atmospheric pressure, so the flow will be reduced, which may cause a difference when you are changing the patient from an ITU vent to home ventilation. The flow will often feel different for the patient, so you may need higher pressures. They have a single limb with either an active exhalation valve or an intentional leak. You can only entrain oxygen through them, but they do have a very good leak compensation. So this is one of my patients who decided that he wanted to learn to fly. So we can do anything if we put our minds to it. So our home care ventilables must be portable. They must have wheelchair adaptation. They must have a mobility bag. They must be able to be locked, because little grandchildren's fingers can come along and change things. And ye old ventilators, like the old nippies, where they used to look like a vanity bag, you could open the box and then turn the knob. So we should be able to lock them. They should have an internal battery, and they must have access to external batteries, especially if you want to go on a long trip. They must have alarms that are appropriate, but not too many that impact upon the patient's quality of life. So be pragmatic with them. Most of them should have a telemonitoring platform now, so we can actually see what the patient's doing, which also helps with our clinical governance. And patients should always be under the local long-term ventilation team to know what to do with those ventilators, and those ventilators should be then prescribed by the long-term ventilation team. And therefore they should have a service contract, so that if something goes wrong, there is a 24-hour call out. And that again will reduce risks. So how do we transition from a home care ventilator, from an ITU ventilator onto a home care ventilator? Well, again, that's going to be prescribed by the long-term ventilation team. You must make sure that the gas exchange is optimised by the current ventilator settings. And then what we try to do is match the current settings to the individual needs. So we will set our mode, our IPAP, our EPAP, our TI, our backup rate or respiratory rate, our trigger, our rise. And we need to set the alarms, as I said before, keep them simple but safe. So, for example, if a patient was on an ITU vent in a pressure support mode and the pressure support was 20 and the PEEP was 5 and the patient had an intrinsic rate of 12 to 16 breaths per minute, I would then set the home ventilation mode up onto an ST, spontaneously timed mode. I'd put the IPAP up to 25, I put the EPAP to 5, so I got that total pressure support of 20. I'd set the TI of 1.4 and a backup rate of 14. So that's really important. Then you would adjust to the patient comfort, and often it's just because the flow feels different. So you may want to increase your IPAP, and you may want to increase your rise time, you may want to increase or decrease the TI. But you look for chest excursion, you look at the patient's respiratory rhythm, you look at the patient's reaction and get them to feedback of how they feel. Is it good like this? And sometimes, I mean, recently it took me 4 hours to set one patient up onto a home care ventilator, because we tried every mode and eventually we got there in the end. And they may need a sigh put into that prescription as well. And sometimes patients really like that sigh. They may need a dual prescription, so they may need a prescription for daytime, they may need a prescription just for nighttime, or they may need a prescription that when they're unwell, they'll go on to that prescription, and when they're well, they'll go back onto the normal prescription. So again, it is patient driven. And again, you're going to write that in a passport for them. And before the patient is discharged, you need to find out how ventilator dependent that patient is. Can they come off for any time at all? Can they come off during the day, or are they really ventilator dependent? Because that will then increase your risks, and therefore that will change the way you teach your carers and how you teach your carers. Do the family want to be involved with the care? A lot of the families that I work with do not want to be involved with the care. They just want to still be their wife or their husband or their daughter or their son. So, but some do. So do we incorporate them? Do we teach them how to change the tracheostomy tube? Does the patient want to go back to work? Can they go back to work? And I think that's really important as well. There's no reason why they shouldn't. We should be able to enable them to do so. And is the patient's home suitable, or does there need to be changes in that patient's home to make it possible for them to get home? So again, you're going to look at all the risks and try to reduce them as pragmatically as you can. So what we usually say that if you're discharging from an ITU, we try to send them to a specialist or intermediate care facility to step down from the medical environment, because we need to start looking after their psychological well-being. An acute intensive care unit is not good for psychological well-being. It may give them time for home adaptation, time for the recruitment of and training of carers who are going to go home with them, and it may give us more time for further weaning and optimization. If you're going to discharge patients straight from an acute ITU, it will take longer. So going home, we need to be on a local team of the local tracheostomy and ventilation team. There should be 2 home ventilators. There should be a heated wire humidifier. There should have healthcare funding approved, whatever care system you're in. The care agency or care home should be identified, and a nurse-led package of care with trained carers, which is what we do in the UK, should be identified. All the consumables and other equipment should be ordered. All the ceilings of care should be agreed for that patient, and also that the patient is in agreement if they can. And we should have pathways back to hospital that have been developed and agreed, because there will be times when the patient has to go back to hospital. If they're trachea ventilated, they will in the UK have to go to an intensive care environment. The education and training of the care agency should be directed by the long-term vent team, because they should be the point of contact in the community. And there should be regular hospital, home or mixed reviews. So we can have hospital reviews, we could have virtual reviews. The long-term ventilation team will go in to do regular reviews as well. The care agency and the care team should have safe to practice standards. So you're going to reduce those risks. So these are your competencies. And those carers should have advanced skills. So they should be skilled in changing routine and emergency tracheostomy tubes. It's no good waiting for our paramedic teams in the UK to come, because they do not know how to change tracheostomy tubes at this time. There should be a yearly review of those carers' advanced skills and safe to practice standards, and that review should be undertaken by the long-term ventilator team. And it means that also that the carers and the registered nurse of that care team need to get to know the patient and family and their little nuances and how best to care for them and enable them. So again, we need to teach them how to do individual emergency algorithms and what those emergency algorithms mean. And they should be very simple to use and should reflect the individual patient. We need to reduce medical monitoring of these patients. We need to develop a routine with the patient and their carers. We need to ensure the ceilings of care. We need to learn to enable that person to be. And once they're at home, we need to have long-term ventilation team to lead the regular reviews, and that's collaboration with all the clinical teams inside and outside the hospital. So the local general practitioner, the community physiotherapist, the community speech and language therapists, maybe the OTs, the other clinical teams within the acute care setting who the patient might be under. I believe that there should be, for every tracheostomy patient in the community, a yearly scope of their airway to ensure that everything is going well. If that patient has a very bad scoliosis, again, I would suggest that they have a CT scan on a yearly basis to look at and see where that tracheostomy tube and where it's impacting. And at home, we can review if there's any further weaning to be had. So just because they've gone home with a trachea ventilator doesn't mean that they may have to stay on it. And recently, I decannulated somebody after having a tracheostomy for 20 years, and this has changed his life. So never say never. We look at the competency of the care team and we review that. And this is a whole circle that goes around and around. And to finish off, I want just to share with you my patient who decided to pilot the plane because a life is worth living. Thank you very much.
Thank you very much, Debbie. Thank you very much also for all of you on the call here to send in all your questions. We have a number of questions that came in during the talk, and they are coming in as we speak, I see. Let's see if we can bundle them a little bit. There is around the change of the cannula. Do you make a difference in the schedule between cuffed and uncuffed cannula?
Oh, what, for the whole tracheostomy tube change?
Yes.
Yeah, usually we just say if it's going to be a cuff tube, we usually, and if the patient will cope with it, we usually say every month because the cuff tends to start degrading and starts losing the pressure much more quickly. So if the patient is cuff reliant, then we tend to change that tracheostomy tube that's cuffed every month.
Also, in changing the cannula, there is the question: is that the family doing it? Are they trained and allowed to do it? And how often do you check their skills?
So with the family, if they want to do it, there's not many who do. Mostly the family do it with paediatrics. With the adult patients, they tend not to do it. I've got a couple who do because they're often going away on holiday and on cruises. And I do a yearly review of their skills, but they're trained usually by me or my team on how to change it, and I'll change it with them, and we usually have about 10 changes before I feel that they're competent enough.
Okay. What is the recommended tracheal cuff pressure?
It's around about 20 to 30 millimeters of mercury, or millimeters of mercury. Depends. So in acute care, we get a bit obsessed with the right cuff pressure because you don't want to cause damage. However, when it's a long-term tracheostomy tube, sometimes you have to have a higher pressure to cope with the leak because you tend to start getting a bit of tracheal malacia as the patient gets older and is living longer. So sometimes the patient doesn't like it at the normal level, and you say there is a risk, and you go, this is fine. So you just put the cuff up to stop the leak. So sometimes we go by the cuff pressure, sometimes we don't. Again, it's an individual thing. So that's the difference between acute care to community care. And again, it's on an individual basis.
A question around weaning from the cannula. How do you wean from a cannula? By downsizing is the question.
Yeah, so it depends on what you want the patient to do. If the patient can speak and you want to get some nice airflow, or even if you can't speak but you want to get some airflow, so that might reduce your secretion load. So sometimes when you've got a cuff trachea and you've got no upper airflow, you're going to have lots more secretions. If you can get that cuff down and then you can get them to manage their secretions a little bit more, you can get those secretions to be reduced. And sometimes even with that size tracheostomy tube, I would downsize, so you then get much better airflow when you've got that cuff down. And you just downsize. I never go, if you're going to have depending on the tube, again, you've got different tubes are different inner diameters as well, so that's going to be a problem. So knowing your tubes is really important. If you don't know them, go to your local ENT people because they know all the tubes. They're really good at it. Because often with a Portex 6, I would not put a Portex 6 cuff tube in somebody because the inner diameter is too small, especially if it's cuffed. If it's uncuffed, it's fine, but with a cuffed size 6 Portex, it's too small. It's not enough, and you'll often get a lot of sputum plugs with those.
There's like 3 very similar questions, so I'll just ask one of them. It's around competency documents. Do you have specific competency documents you use with your carers when completing training?
I do, and they're from the Brompton, and so that goes along with their care agencies' competencies, but we have specific Brompton community competencies that we have developed, and basically they're the same, mostly the same as most long-term ventilation teams' competencies. It's just got the Brompton logo on, but yes, they are specific for tracheostomy and ventilation, specific to our long-term ventilation team at the Brompton.
There's a couple of questions now around equipment, ventilator, rescue equipment, and so on. One is, beside pressure support ventilation and using BiPAP ST mode, what other modes can be used? And do you have experience with pressure control ventilation? And if so, what settings would you use?
Okay, all my patients are on every mode you could think of that is out there. So hybrid modes, pressure control, pressure support, ST. Pressure control often suits a lot of patients because you've got a mandatory rate all the time. And if they've got a bit of hypoventilation, especially at night time, you know you've got your mandatory rate there. A lot of spinal cord injuries love to have pressure control. I recently put a patient with intrinsic lung disease who's a CF patient on a pressure control. She was batting along in intensive care. She's on pressure support, and her intrinsic rate was around about 28 to 30. As soon as I put her on the pressure control mode with a rate of 18, her intrinsic rate came down, and she was allowing the mandatory rate to take on her breathing, and she actually calmed down, and we were able then to get her cuff down, so she wasn't so anxious. So, and again, pressure control will be, the settings will be demanded by the patient. But again, when you're first putting the patients on, I try to match what they're on, but often that doesn't work, and we will have to then go through all different modes. And again, it's knowing your ventilator and the nuances that that patient is reacting to when you're doing the changes. And the nicest thing about, I think, about the home ventilators, that there are lots of comfort strategies now within them that you can use with rise times, with size, and it's just much more effective for the patient. So you can just watch them, and you know, and it is that attention to detail and watching them and seeing how comfortable they are.
One more here around the circuit type this time. You mentioned both single limb active exhalation and leak circuits. Which do you prefer and why?
The a leak circuit is the one I prefer, the intentional leak, purely because it's a simple setup. There's not too many other tubes going here, there, and everywhere. So I'll tend to sort of use the most simplest circuit first, and if the patient gets on with that, then fine. Also, because you're having to think about the carers changing that circuit on a two-weekly basis, and so you're trying to keep things very simple. I like things simple. If the patient doesn't like that and they don't like the PEEP, then I'll often use an intentional leak and an active valve. But most of my patients will be on just a simple leak circuit.
Okay, thank you. Well, the first question that came in during your talk is the question to talk a bit more about the usage of the dilator.
So I think I've used a tracheal dilator once in my 40 years as a nurse. I have only seen it used in an emergency in ITU, and then it was badly used by the anaesthetist. So that's why I would never use them. And I've seen a patient in the community have a ruptured trachea because a carer pushed in the tracheal dilators too hard and ruptured the trachea. So that's why I won't use them. The carers don't know how to use them. You need to be skilled in using them. Most of the time, if you know that the tracheostomy stoma is a high risk, and that's one of your red flags, that when you take that tracheostomy tube out, the stoma goes boom and closes very quickly, then don't do that at home. Go into the hospital in a safer environment. And I think, again, it's knowing your patient and being showing how you are going to reduce those risks.
Thank you. follow-up, yeah, a number of questions around the cannula and the track tube. In hospital setting, the inner cannula, how many times can it be used? Is it reusable?
So what we say is that, yes, in the hospital, we can reuse those up until the time the tracheostomy changes in a month. If the actually inner cannula looks like you cannot get it clean and it looks damaged, throw it away and get a new one. So we always reuse the inner cannulas. We clean them, and in hospital we clean with sterile water and then dry them, and then put them in a lidded container by the patient. If it looks damaged, we will throw them away, but they should last at least 2 or 3 weeks at a time.
Okay, a question from the US. Do you see a lot of Jackson metal tracks in home patients?
We don't have Jackson, unfortunately, as much as I'd like them. We used to have Silver Negus. Silver Negus now are not being made by the company Phoenix anymore. There is a German company now, I think, who are now coming to England to show us the UK to show us their silver trackies. I've got about 5 patients with silver trackies who absolutely adore them, so they're desperate to keep them. And you know, some of them are really good. I've had one patient who's actually been allergic to silver, so that wasn't so good. But no, but I'll try anything that's going to suit the patient.
Yeah. 2 more questions. First one is, what type of track tube is commonly used for pediatric patients in the UK?
That's a good question. It's usually Bivona or Shiley. That's the ones we've seen. It's usually Bivona or Shiley. They're the most common ones used.
Yeah, well, one other comes in, but first I'll take this one. Do you check arterial blood gases or serum bicarbonate to gauge if ventilation is okay?
So our long-term ventilation team who go out for our outreach patients, when we go and see them in the community, will do a capillary blood gas on them when they need it. We usually do a capillary blood gas depending on when they're seen. If they're seen monthly, we'll do a capillary blood gas monthly. If their ceilings of care is that no further changes in ventilation, then we don't bother to do capillary blood gas. Again, it's going to be based on need, but we do capillary blood gases in the community. We also do transcutaneous CO2 monitoring with our TCMs, and we can do sleep studies at home. So if there's an issue of looking at whether a patient needs to be on the ventilator at night time, we'll often do a sleep study at night to see actually, does this patient still need ventilation or not? So again, it's based on the individual.
Thank you. The last question now. There's a lot of material in the emergency bag. Do you think that a hand suction pump is useful?
No, it's too much enough. They've got their 2 suction machines anyway that they'll take with them. So no, there's a nice, actually a tiny little suction machine that Lairdale do now. That's the one we say to take out with, because it's very good.
Okay, no further questions here in the chat. So thank you very much, Debbie, for a very interesting and entertaining presentation on how to care for the patients who need a long-term tracheostomy tube.
Thank you very much.
Thank you very much to all of you who attend our webinar here.